2.1 Introduction. Academic counselor Dr. Mahima was again having session with her learners and they were discussing about certain psychological disorders. Let us have a look at their conversation. Dr. Mahima: Hello learners. Learners: Hello ma'am. Dr. Mahima: So in the last session we discussed about schizophrenia. Can any one of you tell me about it? Jenny: Learner: Ma'am, we discussed that schizophrenia is a broad spectrum of condition that affects individuals' cognitive and emotional functioning, including delusions and hallucinations, disorganized speech, behavior and inappropriate emotions. Seema: Learner and Ma'am, the symptoms of schizophrenia can be categorized into positive symptoms, negative symptoms and disorganized symptoms. Dr. Mahima: Yes Jenny and Seema, that correct. What else did we cover in the session? Rizwana: Learner and Ma'am, we also discussed about various biological, psychosocial and cultural causes of schizophrenia. Seema: Learner: Also Ma'am, we looked at the treatment of schizophrenia. Dr. Mahima: Yes, that's correct. Well learners, in today's session, we will discuss about another significant psychological disorder, that is mood disorder. Navjio: Learner: Ma'am, does this have to do with mood swings? Dr. Mahima: Well Navjio, it is definitely more than mood swings and can be explained as serious changes in a person's mood that may lead to distress and dysfunction. And mood disorders are mainly classified into unipolar and bipolar mood disorders. So let's discuss mood disorders further. Learners: Yes ma'am. In the present unit, we will look into mood disorders, their prevalence, causal factors and the treatment options. A serious aspect of mood disorder is suicide. The last section of this unit will focus on suicide and suicidal ideation. 2.2 Mood disorders, an introduction. Mood disorders are serious changes in one's mood that may lead to distress and dysfunction. Mild mood disturbances are on the same continuum as mood disorders. A typical person experiencing fluctuations in mood in everyday life is different from a person with mood disorder only in terms of degree and not in the kind of emotions experienced. This is known as dimensional approach to mood disorders. People are able to bounce back from periods of sadness /euphoria to normalcy, unlike people with mood disorders. Typically, a person is able to feel normal after a short duration of time. They experience relatively greater degree of control over their mood than people with mood disorder. A discussion on mood disorders warrants a distinction to be made between the terms mood and emotion. Emotions are short-lived effect with usually a known cause. However, mood is longer-lasting emotions with no clear starting point. There are diverse kinds of emotions such as joy, pride, anger, guilt, sad, etc., whereas mood is classified as positive or negative. Studies indicate the incidence rate of mood disorders is on the rise. Almost 20% of adults and 50% of youth report recent symptoms of depression. Kessler. According to World Health Organization, approximately 9% of people in India have reported having an extended period of depression within their lifetime. Relative to unipolar mood disorder, bipolar disorder is less common with lifetime prevalence rate to be about 3.9%. Average age of onset is somewhat younger for bipolar disorders than unipolar disorders. For bipolar I disorder is 18 years and for bipolar II is between 19 to 22 years, although cases of both can begin in childhood. It is considered rare for someone to develop bipolar after the age of 40 years. Gender differences in unipolar disorder are seen with higher number of women, 2:1, receiving diagnosis of depression. However, gender differences are not present for bipolar disorder. With respect to the age of onset, Although severe depression and dysthymia usually begin in late adolescence or early adulthoods, mid-20s, but they can occur at any age. It is not uncommon for many adults to have depression for several years before seeking treatment. Diagnosis is most common between the ages of 30 to 59 years. Studies have found that less than half of the people with major mood disorders sought treatment. Mood disorders are highly comorbid with anxiety, personality disorders and substance abuse disorder. Mood disorders are classified as unipolar and bipolar disorder. Bipolar disorder was earlier known as manic depression. In the next sections of this unit, let us now focus on unipolar and bipolar mood disorders. 2.3 Unipolar mood disorders. In unipolar mood disorders, a person experiences extraordinary sadness/depression. The types of unipolar mood disorder are major depression, clinical depression, and persistent mood disorder, dysthymia in DSM-4. On the basis of duration and severity of depressive symptoms, unipolar mood disorder is classified into two types, namely, major depressive disorder, MDD, and dysthymia/persistent mood disorder. MDD is considered to be more severe but of shorter duration, whereas dysthymia is relatively less intense but lasts for a longer duration. Generally, the symptoms of depression can be classified as affective, cognitive, and physical. 2.3.1 Major depressive disorder. Rajesh, a 38-year-old unemployed man, had been feeling frustrated with his life over the past few months. Family reports that they noticed a number of changes in him after he lost a lot of money in a business venture. He began to spend a lot of time alone in his room. His mother would serve him food but he would not eat it, instead would just stare at it. He used to enjoy going for morning walks and spend time with his children, but lately had stopped doing both. Initially, the family thought that he was upset over the failure of his business, and would soon snap out of it. But over the period of next few days he became more and more miserable and refused to talk to anyone. He would sleep till the afternoon and then spend most of his day on his bed. The family brought him to a psychiatrist after they found him one morning standing by the window crying uncontrollably and saying he just wanted to end everything. Major depressive disorder, MDD, is one of the most easily recognized depressive disorders. It is defined by absence of manic or hypomanic episode before or during the disorder. According to DSM-5, a person experiencing MDD episode has depressed mood and or loss of interest or pleasure in life activities for at least 2 weeks. MDD is an episodic disorder, that is, the symptoms are present for a period of time and then the person recovers. An untreated episode may stretch for 4 to 9 months. Generally, MDD consists of recurrent episodes of severe depression. Approximately 40 to 50% of people with initial episode will go on to experience another episode. The probability of recurrences increases with the number of prior episodes. Occurrences of isolated depressive episodes are rare. Thus, MDD is usually a chronic condition, consisting of recurrent depressive episode, with average number of episodes for an individual to be 4. DSM-5 lists the 9 symptoms for MDD episode. A person needs to be diagnosed with 5 out of 9 symptoms for diagnosis. While making diagnosis for depression, it is important to specify whether it is 1. Initial /first episode, 2. Recurrent episode, preceded by 1 or more previous episodes separated by at least 2 months with recover in between, or 3. Chronic, although rare. In some cases major depression does not remit for over 2 years. The symptoms of major depressive disorder include depressed mood most of the day. Depression is not temporary sadness that lasts for a day or two or only part of the day. It is experience of significantly low mood for different times of the day for almost every day of the week. For instance, Rajesh was upset and was found crying uncontrollably for almost every day of the week. Anhedonia / loss of pleasure. MDD is not just a state of high negative affect but also low positive affect. In fact, anhedonia or the loss of ability to experience pleasure is considered to be far more characteristic of severity of MDD than reports of distress / sadness. A person suffering from MDD may lose interest in all those activities that they may have found enjoyable, such as going to school / work, being with friends and family, watching movies, eating good food, and hobbies. The individual may withdraw from people and activities as they no longer gets pleasure from them. Rajesh enjoyed going for morning walks and spending time with his children, but had stopped doing both. Psychomotor retardation or agitation noticed by others. Evidence suggests that the most central indicator along with anhedonia is a somatic or vegetative state. A person with MDD exhibits behavioral and emotional shutdown. It is described as feeling slowness or having trouble in gathering energy to get up. Consequently, the person might want to just lie all day on the couch, surf internet, watch TV, or sleep a lot. For instance, Rajesh found it hard to get up every morning and get out of his bed. People with very severe cases may be so slowed down that they may not move any muscles for hours, vegetative state. While some people experience psychomotor retardation, others may find it extremely difficult to sit still. They are likely to be in a state of psychomotor agitation, pacing about in a room, wringing one's hands, pulling off clothing and putting it back on, continuously fiddling with objects, keeping them down, and then fiddling again, and other similar actions. Fatigue or loss of energy. Apart from psychomotor retardation, physical symptoms of depression include fatigue and low energy as well as physical aches and pains. Such symptoms may make people believe that they may be suffering from some medical condition, even though there are no physical cause for the aches and pains. Insomnia or sleeping too much. Hypersomnia. Although some people with MDD may experience exhaustion, aches and pains, they may find it difficulty in sleeping and may wake up frequently. They may wake up very early each morning, lying in bed until it is time to rise, early morning wakening. Conversely, some people like Rajesh may have a heavy feeling of fatigue and loss of energy that leads to oversleeping. Oversleeping may be seen as a way to escape the extreme sadness felt in awake states. Significant unintentional weight loss or gain. People with depression may fail to eat, complaining of finding food to taste bland or not feeling hungry, thereby losing significant amount of weight. Unlike Rajesh, who had stopped eating when offered food by his mother, other people with depression may often overeat to compensate for experience of intense sadness. Feelings of worthlessness and guilt about things beyond their control. Cognitive symptoms of depression include increased focus on one's flaws and deficits. The individual is likely to be highly self-critical. For instance, they may blame themselves for not being a good son, friend, or father, may call themselves good for nothing, useless, stupid, not good enough, loser, etc. A victim of abuse may continue to blame themselves for their condition. Diminished ability to think or concentrate, or indecisiveness. Another cognitive symptom of depression is the inability to pay attention or make decisions. Patients of depression describe that paying attention can prove to be very exhausting, leading to problems at work and school. The inability to perform well at work and school further deteriorates feeling of worth and self-esteem. Recurrent thoughts of death. Low positive affect, high negative affect, problems with sleeping, eating, loss of energy, and feelings of worthlessness and lack of concentration may make an individual feel utterly dejected and hopeless. There is a high risk for suicidal ideation and suicide attempts in such individuals. Suicidal ideation refers to morbid thoughts and fantasies about dying, funerals, self-destructive behaviors, such as cutting and burning. A conversation between a therapist and client who is severely depressed. Therapist: can you tell me what do you have planned for today? Client: long pause, well, not sure, might get up today. Therapist: okay, what next, after getting up? Client: well. Long pause. Therapist: yes. Go on. Client: I don't know. I really just want to sleep. Box 2.1, DSM-5 Criteria for Major Depressive Disorder. The individual must be experiencing 5 or more symptoms during the same 2-week period, and at least one of the symptoms should be either 1. Depressed mood, or 2. Loss of interest or pleasure. 1. Depressed mood most of the day, nearly every day. 2. Markedly diminished interest or pleasure in all, or almost all, activities most of the day, nearly every day. 3. Significant weight loss when not dieting, or weight gain, or decrease or increase in appetite nearly every day. 4. Sleep disturbance, insomnia or hypersomnia. 5. A slowing down of thought and a reduction of physical movement, observable by others, not merely subjective feelings of restlessness or being slowed down. 6. Fatigue or loss of energy nearly every day. 7. Feelings of worthlessness or excessive or inappropriate guilt nearly every day. 8. Diminished ability to think or concentrate, or indecisiveness, nearly every day. 9. Recurrent thoughts of death, recurrent suicidal ideation without a specific plan, or a suicide attempt or a specific plan for committing suicide. B. At least one of the symptoms is anhedonia or low mood. C. The symptoms cause clinically significant distress or impairment in social, occupational or other important areas of functioning. D. The episode is not attributable to the physiological effects of a substance or another medical condition. E. There has never been a manic episode. 2.3.2 Dysthymia / persistent depressive disorder. Mia is an 18-year-old college student went to college counselor because he felt that he was suffering from depression. Even though he was performing well in class, he complained of feeling a constant sense of tiredness. However, along with feeling tiredness, he also felt blue, down and hopeless since a very long time. He described himself as being a loner and did not have any friends since school. He felt nobody wanted to be his friend because he was uninteresting and boring person. He shared that his parents would constantly fight. His mother wanted to separate from her abusive husband but was unable to do so because she was concerned about Mia's future. It soon became clear that he never really felt loved by his parents. Mia admitted experiencing a vague sense of guilt for his parents' conflicted relationship. Lives of my parents would have been better if I was never been born. Dysthymia or persistent depressive disorder, as DSM-5 calls it, shares many features with major depressive disorder, but is different in 2 regards. First, dysthymia has fewer and less intense symptoms, and second, depression lasts for a long period. Depressed mood in dysthymia may last for most of the day, but the depression is of mild to moderate intensity. The central feature of dysthymia is its chronicity. DSM-5 specifies chronic feeling of depression for at least 2 years. On an average, people with dysthymia have had mild-moderate symptoms for 5 years, but in some cases, it may last for 20 years or more. It includes intense feeling of being sad most of every day with relief from symptoms never longer than 2 months at a time. Box 2.2, DSM-5 Criteria for Dysthymia / persistent depressive disorder. A depressed mood for most of the day, for more days than not, as indicated by either subjective account or observation by others, for at least 2 years. B. Presence, while depressed, of 2 or more of the following: 1. Poor appetite or overeating. 2. Insomnia or hypersomnia. 3. Low energy or fatigue. 4. Low self-esteem. 5. Poor concentration or difficulty making decisions. 6. Feelings of hopelessness. C. During the 2-year period, 1 year for children or adolescents, of the disturbance, the individual has never been without the symptoms in criteria, and B. for more than 2 months at a time. Criteria for a major depressive disorder may be continuously present for 2 years. D. There has never been a manic episode or a hypomanic episode, and criteria have never been met for cyclothymic disorder. E. The disturbance is not better explained by a persistent schizoaffective disorder, schizophrenia, delusional disorder, or other specified or unspecified schizophrenia spectrum and other psychotic disorder. F. The symptoms are not attributable to the physiological effects of a substance, for example, a drug of abuse, a medication, or another medical condition, for example, hypothyroidism. G. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Double depression. Individuals with double depression meet the criteria for both major depressive disorder and persistent depressive disorder. In a typical case, at an early age mild-moderate intensity of depressive symptoms develop first, the person in this case likely to be relatively more functional, and then 1 or more MDD episodes occur only to revert to dysthymia once the MDD has run its course. Double depression is difficult to ascertain unless a professional who has been seeing the client with dysthymia since some time spots sudden or gradual worsening of the client's symptoms. It is important for professionals to recognize double depression, as it is associated with poorer prognosis, that is, high rates of relapse and recurrence. 2.2.3 Additional defining criteria for depressive disorders, specifiers. Some individuals who meet the basic criteria for diagnosis of major depression may also meet additional patterns of symptoms called specifiers. Specifiers influence the course of the disorder and effective treatment. Psychotic features. In MDD with psychotic features, the person in midst of a depressive episode may experience loss of contact with reality and delusions or hallucinations. Mood-congruent hallucinations / delusions have negative tone, themes of personal inadequacy, guilt, deserved punishment, death, and disease. For example, one's internal organs have totally deteriorated. In rare condition, it may be severe and may mark the beginning of schizophrenia. It could be possible that the patient may have had symptoms of schizophrenia to begin with. The clinician in this case may consider possible diagnosis of schizoaffective disorder. MDD with psychotic feature is difficult to treat, responds poorly to treatment, is associated with greater impairments with fewer weeks of minimal symptoms. Anxious distress features. The individual exhibits severity of anxious symptoms, which may meet criteria for anxiety disorders, comorbidity, or do not meet full criteria for anxiety disorders, subthreshold. Presence of anxiety indicates a more severe condition, suicidal ideation and completed suicides more likely, and poorer outcome of treatment. Mixed features. The person is predominantly experiencing depressive episodes but also experiences several, at least 3, symptoms of mania. Many researchers find bipolar to be a misleading label. This is because clinicians have noted occurrences of mixed episodes, that is, a person with bipolar disorder may not always alternate between the opposite ends of the depression-elation continuum. Instead, in a mixed episode a patient may become anxious or depressed about experience symptoms of mania as being out of control, reckless, dangerous, and racing thoughts. Mixed episodes may be more common than previously thought. In one study it was found that about 30% of the patients hospitalized for acute mania had mixed episodes. Melancholic features. This specifier only applies in case of major depressive disorder, separately or in double depression. The person with MDD with melancholic features has lost interest in almost all activities or desired events, anhedonia. They experience more severe physical symptoms like significant psychomotor retardation, early morning awakenings, weight loss, and loss of libido. Atypical features. This specifier applies to both MDD and dysthymia. It is used for people who display unusual depressive symptoms. Relative to most people with depression, those with atypical features consistently oversleep /overeat during their depressive episode and thus gain weight. The person's mood may brighten in response to positive events. Postpartum onset specifier. The onset of major depressive episode occurs during the postpartum period, 4 weeks immediately after childbirth. For the woman and her family, it may be difficult to understand why they are depressed because they are expected to be joyous at the arrival of their baby. Seasonal pattern feature. At least 2 or more episodes in past 2 years that have occurred at the same time, usually in winter, and full remission at the same time, usually spring. There are no other non-seasonal episodes in 2-year period. MDD with this specifier is called seasonal affective disorder, SAD. SAD is related to secretions of melatonin hormone and circadian rhythm. Catatonic feature. MDD with catatonic feature is rare. Catatonia is serious absence of movement in which patient's arms or legs remain in any position in which they are placed, waxy flexibility. Catatonia was earlier associated with schizophrenia. Recent studies suggest it is more common in depression than schizophrenia. 2.4 Causal factors of unipolar mood disorders. A number of different causal factors have been studied in context of the etiology of unipolar mood disorder, including biological, psychological, and socio-cultural factors. Researchers believe that interaction between these causal factors, that is, the biopsychosocial model. 2.3.1 Biological factors. There are many different approaches to understand the biological factors underlying the development of unipolar mood disorders. Researchers have found the possible role of genetics, neurochemistry, hormones, neuroanatomy, neurophysiology, sleep and circadian rhythms. Genetics. Family studies report that first-degree relatives of a person who has depression have an increased risk, about 2 to 3 times higher, to develop depression than relatives of control group. Also, factors such as severity, recurrence of major depressive episodes and earlier age of onset are associated with higher rates of depression in relatives. Twin studies have also found higher concordance rate for depression in identical twins relative with non-identical twins. Moreover, concordance rates are found to be higher for females than males. Adoption studies also provide support for genetic basis of unipolar mood disorders. Chances of unipolar depression were higher in biological relatives of adopted children than in biological relatives of control adopted children. The serotonin transporter gene, which is involved in transmission and reuptake of the neurotransmitter serotonin, has been identified. Researchers in the field believe that there is no one faulty gene underlying depression. In fact, there are several patterns of genes. Genetic factors have been found to underlie the temperament of neuroticism that predisposes an individual to both anxiety and depression. Taken together, family, twin, and adoption studies make a strong case for moderate genetic contribution to the causal pattern of depression, but not as large a genetic contribution as for bipolar disorder. Genetic factors may provide a diathesis for development of depression. Faulty genes may produce neurochemical, neuroanatomical, neurophysiological and hormonal changes in an individual. Neurotransmitters, electroconvulsive therapy and antidepressant medicines found to be effective in case of unipolar depression suggest neurotransmitter activities to play a role in depression. Such findings have led to the development of neurochemical theories of etiology of depression. The monomin hypothesis of depression presented in 1960s-70s focused on three neurotransmitters of the monomin class, namely, norepinephrine, dopamine, and serotonin. According to the monomin hypothesis, depression is a result of absolute or relative depletion of the one or all of these neurotransmitters at important receptor sites in the brain. Depletion is hypothesized to be because of either 1. Reduced production, 2. Increased degradation of the neurotransmitters at the synapse, or 3. Altered functioning of the postsynaptic receptors. Follow-up studies found some contrary evidence to the monomin hypothesis. First, some studies have found that there may actually be an increase in norepinephrine, a class of monomin neurotransmitters. Second, only a minority of patients with depression, that is, those with more severe symptoms and suicidal ideas, had reduced serotonin activity. Third, medicines immediately increase the availability of neurotransmitters, but they take about 2 to 4 weeks to show effect. Finally, it was found that people with depression did not have disturbance in the absolute level of neurotransmitters. By 1980s, it was clear that a straightforward mechanism is not possible. Newer studies suggest that depression may be related to the sensitivity of postsynaptic receptors, that is, reduced sensitivity for dopamine and serotonin levels. Serotonin in particular has been implicated in unipolar depression. People who are vulnerable to depression may have less sensitive serotonin receptors. Apart from serotonin, reduced sensitivity to dopamine is related to anhedonia, lack of motivation and energy. Most recent studies have focused on the interaction of neurotransmitters and hormones, brain activity, and biological rhythms. Endocrine system / hormones. In search for identifying the causal factors underlying depression, attention has moved from a focus on neurotransmitters to the endocrine system, in particular the hypothalamic pituitary adrenal (HPA) axis. According to the stress hypothesis, people with depression have dysfunction in the HPA axis, leading to the increased blood plasma levels of cortisol, stress hormone. Thus, cortisol levels are poorly regulated in people with depression. Elevated stress hormone, cortisol, levels are consistent with the relationship between depression and severe stress. High cortisol levels are harmful to neurons. Neurons in hippocampus are affected, leading to problems with memory impairments and problems with abstract thinking. Hippocampus also keeps regulating cortisol. Some researchers suggest that perhaps low hippocampal neuronal volume precedes and contributes to onset of depression. The findings are supporting of evidence that has found that treatments for unipolar depression like electroconvulsive therapy and exercise promotes neurogenesis in hippocampus. Another hormonal system, the hypothalamic pituitary thyroid (HPT) axis, has been linked to depression. About 40 to 60% of depressed patients show dysregulation of the axis. Neuroanatomy and neurophysiology. Neurofunctional studies have found many regions of the brain are functioning atypically. Overactivity has been reported in amygdala that is related to oversensitivity to emotionally relevant stimuli. Those systems involved in weighing rewards and costs, making decisions, and systematically planning and pursuing goals in the face of emotions appear less active. That is, face of emotional stimuli, for example, experience of failure. A person with depression responds with increased emotion but has decreased ability to plan, to deal with the stimuli. Apart from the brain systems involved in emotion, sensitivity of the brain structures part of the reward system in the brain is also altered. Researchers are trying to understand whether structural and functional changes in brain in depression are cause or effect of unipolar depression. Sleep and circadian rhythms. The common sleep problems in depressed outpatients show a variety of patterns like early morning awakenings, periodic awakening during night, and difficulty falling asleep. Studies have found that people with depression enter REM sleep more quickly, usually after an hour when typical people take about 1.5 hours, and have lower than normal amount of deep sleep than normal. Sleep alternations precede the onset of depression and persist following recovery, which suggests that they may be vulnerability markers for certain forms of depression. Apart from sleep, disruption in circadian rhythms, for example, secretion of hormones like thyroid-stimulating hormones, TSH, cortisol, or internal sleep-wake cycle has also been reported in people with early morning awakening or those with depression with the seasonal feature, seasonal affective disorder, SAD. Seasonal changes in the production of melatonin, hormone secreted by pineal gland, have been related to SAD. Exposure to light suppresses melatonin production and is produced only at night. Its production tends to increase in the winter, when there is less sunlight. Studies have shown that melatonin secretions increase in winter but only in patients with SAD and not in healthy controls. Thus, sensitivity to increase in melatonin is a vulnerability marker to development of unipolar depression. 2.3.2 Psychosocial factors. Evidence for psychosocial risk factors is as strong as biological risk factors. According to the diathesis stress model, neurobiological factors may be the diatheses that interact with the psychosocial stressors leading to development of unipolar depression. Although many people experience psychosocial stressors, not everyone develops depression. Also, many experience psychosocial stressors, but not all become depressed. This is only true for those with biological vulnerability. Psychosocial factors include psychological diathesis, stressful life events, and interpersonal factors. Stressful life events. Many studies have shown that severely stressful life events such as loss of loved one, serious threats to important relationships, or to one's occupation, severe economic or health problems often serve as a precipitating factor, trigger, for unipolar depression. However, the relationship between stressful events and depression is not a simple one. Studies have found that the nature of stressful event is a moderating factor. For instance, events that involve experience of loss, humiliation, and social rejection are likely to trigger depression. Additionally, the perceived severity of the event is an important factor too. Recent and severe stressful life event plays a role in people with first episode of depression, whereas minor and less severe events may be enough to trigger subsequent episodes. Finally, chronic stressors such as poverty, social discrimination, domestic abuse, marital discord, chronic illnesses in family members or oneself lead to increased risk of onset and maintenance of depression. While the relationship between stressful events and depression is well established, researchers are trying to understand whether stressful events cause depression, or does vulnerability to depression cause one to be sensitive to stressful events. Stressors can be understood in terms of independent life events such as loss of job in recession, earthquake, loss of someone close, etc., or dependent life events, that is, those related to one's interpersonal skills, problem-solving and coping skills, such as constant reassurance seeking, poor management of time or self-medication, use of alcohol or drugs to feel relaxed, calm, and sleep. Research suggests that dependent life events play a stronger role in the onset of major depression than do independent life events. Psychological diathesis. an individual high on the personality trait of neuroticism and / or pessimistic attributional style is considered to be vulnerable to unipolar depression. Individuals with neuroticism tend to be sensitive to a broad range of negative moods including sadness, guilt, anxiety, hostility, etc. Those high on neuroticism generally have been found to have poorer prognosis. BAPCH has found that pessimistic attributional style, or the tendency to interpret everyday events in negative way, also makes one prone to depression. Pessimistic attributional style is finding internal, stable, and global attributions to negative events. Such as, it's all my fault, it happens all the time, it happens with everything. Psychological / cognitive diathesis has been discussed later in the unit. Interpersonal factors, early childhood adversity, lack of social support, marital and familial discord, and parental depression have been identified as possible triggers for the development of depression in someone with biological and psychological diatheses for development of childhood adversities like losing a parent early in life, parental depression, family turmoil, physical or sexual abuse, intrusive, harsh, neglectful and coercive parenting can make an individual vulnerable to development. Supportive and healthy relationships can play a supportive role in people with vulnerability to develop depression. Conversely, socially isolated individuals or those with smaller and less supportive social networks tend to become vulnerable to becoming depressed. Lack of social support can form a reciprocal relationship with depression, since behavior of people with depression may produce sympathy in short term but in long term may lead to neglect, rejection by others. Similarly, two-way relationship has also been found for marital and familial discord. Domestic discord can lead to depression, and depression can in turn lead to heightened domestic discord. 2.4.3 Theoretical perspectives on unipolar depression. The different theoretical perspectives in depression provide explanation for unipolar depression. The cognitive behavioral theories of unipolar depression have proven to be effective in its treatment, whereas psychodynamic explanations of depression explains it as a result of excessive and irrational grief reaction to loss, real, imagined, or symbolic, have failed to find support. BAPCH's cognitive theory, one of the most prominent theories of depression, was given by Aaron Beck, who proposed that the cognitive symptoms of depression, for example, I'm hopeless, total failure, precede and cause the affective symptoms of depression, for example, upset and miserable. Beck proposed that dysfunctional / depressogenic beliefs that are rigid, extreme and counterproductive are formed during early childhood through interactions with parents and significant others. For example, I must be perfect in everything, I'm unworthy of being loved. These beliefs may lie dormant and form a cognitive diathesis to develop depression in life later on. These beliefs are never challenged and become self-fulfilling. For instance, a person who has a core belief that they are unworthy of being loved may reject loving advances of others and may withdraw from others, making others reject them in turn. Under stressful situation in life called critical incidents, such as those involving humiliation, loss, and social rejection, these dormant beliefs may become dominant and may generate automatic negative thoughts. These thoughts are below the surface level of awareness and are negative and pessimistic predictions about one's self. I'm a loser, others, nobody loves me, and future, it's all hopeless, nobody will ever love me. Beck labeled this as cognitive triad. Cognitive distortion is maintained by cognitive distortions that are errors in one's thinking and leads to biased processing of information. Some examples of cognitive errors are, all or none thinking, I'm either best at something or I'm nothing, overgeneralization, I failed in my job, I'm an absolute loser, arbitrary reference, nothing good can ever happen to me and I can never get well, and personalization, it's all my fault. Automatic negative thoughts can cause depressed mood, and depressed mood in turn can make negative thoughts salient. This has been labeled as the vicious cycle of depression. 2.5 Bipolar mood disorders. People with bipolar mood disorder alternate between depressive and manic episodes on the depression-elation continuum. Bipolar disorders are classified as bipolar I, bipolar II, and cyclothymic disorder. It is rare for mania to occur by itself in the absence of a manic episode. Bipolar disorders were previously known as manic depressive illness. Presence of mania distinguishes bipolar from unipolar disorders. A person diagnosed with bipolar disorder experiences depressive episodes that alternate with manic episodes. Mania can be distinguished into two types depending on severity: hypomania and full-blown mania. Full-blown mania leads to significant occupational and social functioning. Hospitalization is often necessary in case of full-blown mania. Manic symptoms in hypomania are similar, but the severity is lesser. Impairment caused by hypomania is to a lesser degree than for full-blown mania, and hospitalization is not required. 2.5.1 Manic episode. Ankit is 40-year-old man brought to the emergency department with cuts to his arms, chest and face, which he received as a result of a fight on the street. In the hospital, Ankit finds it extremely difficult to stay in bed and is constantly wandering around the ward into other rooms. When he is in bed, Ankit is constantly ringing the buzzer. He is frequently found talking to other patients, staff and visitors about his wonderful new invention. His family was called, who informed the doctors that Ankit has a history of bipolar disorder. Ankit's wife informed that he had been finding it difficult to sleep in the past few days. He had stopped taking his medicines for bipolar disorder. He seemed to be in a good mood and would stay up the entire night working on his laptop. Before leaving the house that morning, Ankit told his wife that he was going to quit his job because he was too good for the job and he was wasting his talent at the job. He told his wife that he was bursting with energy and that he wanted to buy laptops from the market for his new invention. When his wife tried to stop him, he got irritable and aggressive and left the house after pushing her away. Mania is an emotional state where intense elation, unusual irritability, or heightened goal-directed activity or energy exists for at least 1 week. In case of hypomania, the symptoms last for 4 days in a row and are not severe enough to require hospitalization. Hypomania may be experienced as pleasurable as it leads to increased energy and creativity. However, it may have undesirable consequences like suicidal tendencies when the predominant mood is irritable instead of euphoric. Psychotic features are also likely to be absent in hypomania. According to DSM-5, 3 or more of the following symptoms must be present to a significant degree for the diagnosis of a manic episode. Grandiosity refers to inflated self-esteem or the feeling of being able to do something unlikely or impossible. A person may feel they are capable of making great inventions, be in the same league as famous personalities, or be capable of great creativity. People feel on top of the world, with the ability to do great many things. Decreased need for sleep. An individual experiencing a manic episode tends to feel rested with very little sleep. They may experience insomnia and may need very little food. More talkative than usual or pressure to keep talking. In a manic episode, the person may start talking excessively. They experience a heightened need to talk to others. Their speech is paced. Sometimes others may find it difficult to understand them. Excessive speech is related to racing thoughts in manic episode. Box 2.5. DSM-5 criteria for manic episode: a distinct period of abnormally and persistently elevated, expansive or irritable mood and abnormally and persistently increased goal-directed activity or energy, lasting at least 1 week and present most of the day, nearly every day, or any duration if hospitalization is required. B. During the period of mood disturbances or increased activity. 3 or more of the following symptoms must be present to a significant degree and represent a noticeable change from usual behavior. 1. Inflated self-esteem or grandiosity. 2. Decreased need for sleep, for example, one feels rested after only 3 hours of sleep. 3. More talkative than usual or pressure to keep talking. 4. Flight of ideas or subjective experience that thoughts are racing. 5. Attention is easily drawn to unimportant or irrelevant items. 6. Increase in goal-directed activity, either socially, at work or school, or sexually, or psychomotor agitation. 7. Excessive involvement in pleasurable activities that have a high potential for painful consequences, for example, engaging in unrestrained buying sprees, sexual indiscretions, or foolish business investments. C. The mood disturbance is sufficiently severe to cause marked impairment in social or occupational functioning or to necessitate hospitalization to prevent harm to self or others, or there are psychotic features. D. The episode is not attributable to the direct physiological effects of a substance, for example, a drug of abuse, a medication, or other treatment, or another medical condition. Note: a full manic episode that emerges during antidepressant treatment, for example, medication, electroconvulsive therapy, but persists at fully syndromal level beyond the physiological effect of that treatment is sufficient evidence for a manic episode and therefore a bipolar I diagnosis. 2.4.2 Types of bipolar disorder. DSM-5 classifies bipolar disorder into 3 types, namely, bipolar I, bipolar II, and cyclothymic disorder. People with bipolar I disorder experience episodes of full-blown mania and periods of major depressive disorder. Even if the individual does not meet the threshold for a major depressive episode, the diagnosis of bipolar I disorder is still given. A mixed episode characterized by symptoms of both full-blown manic and major depressive episodes for at least 1 week, also receives the diagnosis of bipolar I disorder whether the symptoms are intermixed or alternate rapidly every few days. Bipolar II disorder is characterized by episodes of hypomania and depressed mood that meets the criteria for major depressive disorder. In bipolar II disorder, the person does not experience full-blown mania, or mixed episode. If a person only shows manic symptoms, then it is assumed that the person will experience a depressive episode also or may have experiences symptoms of mild depression that went unrecognized. Finally, cyclothymic disorder is defined as a less serious version of full-blown bipolar disorder because it lacks certain extreme symptoms and psychotic features such as delusions and the marked impairment caused by full-blown manic or major depressive episodes. The depressed mood in cyclothymic disorder is similar to the depressed mood in dysthymia, such as low energy, feelings of inadequacy, social withdrawal, and a negative, brooding attitude. The person's mood is dejected, they experience distinct loss of interest or pleasure in customary activities and pastimes. Similarly, the manic mood in cyclothymia is similar to symptoms of hypomania. The person displays surge in creativity, bursts of energy, increased productivity and physical /mental energy. The duration of cyclothymia is at least a period of 2 years during which numerous periods of hypomanic and depressive symptoms are experienced that cause clinically significant impairment, although not as severe as bipolar I and II disorder. In between there may be significant period of normal mood in which the person may function in relatively adapted manner. Features can be as high-strung, explosive, moody, or even hyperactive. Cyclothymia is a chronic and lifelong condition. Some of them go on to develop full-blown bipolar disorder later in life. 2.5.3 Additional specifiers for bipolar disorder. Along with the diagnosis for bipolar disorder, clinicians make note of specifiers to make a more specific diagnosis. Bipolar disorder has the same specifiers as unipolar disorder, that is, mixed feature, anxious distress feature, psychotic feature, melancholic feature, postpartum feature, seasonal pattern, catatonic and atypical features. In addition, there is another feature called rapid cycling. Individual given this specifier quickly move in and out of depressive or manic episodes, that is, at least 4 manic /depressive episodes in a year. Some people with bipolar can switch to a rapid cycling pattern, but most return to their normal bipolar pattern in time. This pattern is likely to have an earlier age of onset and make more suicide attempts. Rapid cycling is usually temporary and disappears within a period of 2 years. 2.6 Causal factors of bipolar mood disorders. As is the case with unipolar mood disorder, interaction of biological, psychological and social causal factors have been posited. However, in case of bipolar disorders, biological causal factors are clearly dominant, and the role of psychological causal factors has received significantly less attention. 2.6.1 Biological factors. A number of biological factors are thought to play a causal role in the onset of bipolar disorder, including genetic, neurochemical, hormonal, neurophysiological, neuroanatomical, and biological rhythm influences. Genetic factors. There is greater influence of genes in etiology of bipolar disorder than unipolar disorder. Studies report that genes account for about 80 to 90% of variance in the tendency to develop bipolar disorder. The heritability estimates are higher than for any other major adult psychiatric disorders, including schizophrenia. Family studies have found that being related to a person with bipolar disorder, first-degree relatives, increases one's chances of developing bipolar disorder to 9%, which is approximately 1% for general population. First-degree relatives of person with bipolar are also at the risk for developing unipolar mood disorder, although reverse is not true. Twin studies have found concordance rate to be a high 60% for monozygotic twins and 12% for dizygotic twins. Neurochemical factors. The monomin hypothesis posits that depression is caused by decrease in norepinephrine, dopamine and / or serotonin. It was hypothesized that perhaps mania is caused by excess of these neurotransmitters. Some evidence has been found for increased norepinephrine activity and dopaminergic activity in manic phase. Increased dopaminergic activity in several brain areas may be related to manic symptoms of hyperactivity, grandiosity, and euphoria. However, serotonin level has not been found to increase and tends to remain same in manic and depressive phases. Lithium is a natural element and has found to be an effective mood stabilizer. It has been hypothesized that lithium may act as a substitute for sodium ions in neural conduction. Neurohormonal factors, neurophysiological and neuroanatomical, hypothalamic pituitary adrenal, HPA, axis is implicated in both unipolar and bipolar disorder. Cortisol levels are elevated in bipolar depression as well as manic episodes. Neurophysiological and neuroanatomical findings have also failed to obtain any difference in unipolar and bipolar depression. That is, changes seen in unipolar disorder in brain structures, amygdala, hippocampus, cingulate cortex and anterior cingulate cortex, are also seen in bipolar disorder. Differences emerge during the manic phase. Blood flow to the brain increases. Blood flow to left prefrontal cortex is reduced during depression. During mania it is reduced in the right frontal and temporal regions. In normal moods, blood flow across two brain hemispheres is approximately equal. Brain region involved in reaction to reward is overly active. Circadian rhythms. Given the cyclic nature of bipolar disorders, circadian rhythm disturbances have been found to be common in bipolar patients, even when symptoms have remitted. Manic episodes may be precipitated by loss of sleep, pregnancy, postpartum, jet lag, etc. Insomnia is the most common symptom before the onset of the manic phase. During manic phases patients tend to sleep very little. This is the most common symptom. 2.6.2 Psychosocial factors. Although biological factors play a dominant role in etiology of bipolar disorders, psychosocial factors such as stressful life events, poor social support, and certain personality traits and cognitive styles have also been identified as important. Stressful life events are found to precipitate manic/depressive episodes in bipolar life events. Further, stresses in life make recovery more difficult and more difficult to recover from the episodes. It has been hypothesized that stress may disrupt the critical circadian rhythms and trigger manic/depressive episode. 2.7 Socio-cultural causal factors of mood disorders. Depression occurs in all cultures, however the form of depression and prevalence rates are different from culture to culture. Higher rates of depression have been seen in Western/westernized cultures. In cultures like China and Japan the rates of depression are low and the psychological symptoms of depression may not show guilt, pessimistic attributions, hopelessness, instead somatic/vegetative symptoms, aches and pains, lack of energy, sleep and eating disturbances, may be more prominent. This may be because in individualistic cultures, the self is viewed as independent and autonomous. In face of failures in individualistic cultures, internal attributions are made. Whereas in collectivistic cultures, there is reciprocity between culture and individual, and when loss occurs, most likely it is made sure that hopelessness and helplessness do not set in an individual. Also, even where psychological symptoms may be present, somatic symptoms may be given more legitimacy because stigma attached to mental illness and because of the belief in the unity of the mind and body. Socioeconomic status, SES, has been found to be inversely proportional to depression. This may be because low SES leads to increased life adversity and stress. Whereas, bipolar disorder is more common in higher SES, possibly because the personality and behavioral correlates of bipolar illness in hypomanic phases, outgoingness, increased energy, and increased productivity, may lead to increased achievements and accomplishments. Many famous poets, writers, composers, and artists have been found to have bipolar disorder. It has been proposed that either hypomania facilitates creative processes, for example, Vincent van Gogh, or that intense negative emotional experiences of depression provide material for creative activity, for example, Sylvia Plath. 2.8 Treatment of mood disorders. Discussed below are the main treatment options for mood disorders. Biological treatment. Biological treatment of mood disorders includes pharmacological intervention, medications, and other treatments such as electroconvulsive therapy. Since serotonin, norepinephrine and dopamine are implicated in depression, most antidepressant medicines work by increasing the availability of these neurotransmitters. Monoamine oxidase inhibitors, MAOIs, were first used in the treatment of tuberculosis but were found to improve the mood of TB patients. They were the first antidepressants. Monoamine oxidase, MAO, are linked to degradation of norepinephrine in synaptic cleft. Monoamine oxidase inhibitors, MAOI, inhibit the action of MAO, thereby increasing availability of norepinephrine. Since newer evidence has found greater role of serotonin in depression, new antidepressants focus on the action of serotonin. Tricyclic antidepressants and serotonin norepinephrine reuptake inhibitors, SNRIs, have been found to increase both serotonin and norepinephrine. However, they are also found to have more severe side effects like nausea, dizziness, headache, etc. Recently discovered antidepressant selective serotonin reuptake inhibitors, SSRIs, has been found to less effective than tricyclics and SNRIs but have less severe side effects and are thus first line of treatment. Prozac, a SSRI, is one of the most famously prescribed antidepressants. Most antidepressants take 2 to 5 weeks to be effective. Mood stabilizer, lithium, has been found to improve the functioning of bipolar patients. Many patients may discontinue lithium because of the severe side effects such as increased thirst, gastrointestinal difficulties, weight gain, tremor and fatigue. However, discontinuation of lithium can be very risky as the probability of relapse is very high. In more severe cases of depression where medications have proven to be ineffective, doctors may prescribe electroconvulsive therapy, ECT. In ECT, electric currents are passed through electrodes to cause convulsions in anesthetized patients. After ECT is over, the patient has amnesia for the period immediately preceding the therapy and is usually somewhat confused for the next hour or so. Typically, treatment consists of fewer than a dozen sessions. Physicians must make the judgment of use of ECT with a patient by weighing the greater clinical benefits against the cognitive side effects. Apart from ECT, non-pharmacological approaches to treatment of depression include some promise new treatment approaches. Transcranial magnetic stimulation, TMS, is a non-invasive technique in which brief but intense pulsating magnetic fields are delivered to induce electrical activity in certain parts of the brain. Treatment usually occurs 5 days a week for 2 to 6 weeks. This approach has been found to be effective for patients who are moderately resistant to medications. Deep brain stimulation is another approach used in patients who have failed to respond to medications, ECT, and psychotherapy. In this, an electrode is implanted in brains and then the area is stimulated with electric current. Finally, bright light therapy, initially used only to treat season-affective depression, has been also found to be effective in non-seasonal depression. Psychotherapy. Cognitive behavioral therapy, also known as CBT or cognitive therapy, originally developed by BAPCH and colleagues, is a relatively brief form of treatment, usually 10 to 20 sessions, that focuses on here and now problems, has been found to be effective in treatment of depression. The therapy is based on the cognitive theory of depression by BAPCH, in which the patient is taught to systematically evaluate their dysfunctional beliefs and negative automatic thoughts. They are also taught to identify and correct their cognitive errors and to uncover and challenge their underlying depressogenic assumptions and beliefs. Recent evidence has suggested that CBT and medications are equally effective in treatment of severe depression. Behavioral activation treatment is a relatively new treatment that focuses intensively on getting patients to become more active and engaged with their environment and with their interpersonal relationships. These techniques include scheduling daily activities and rating pleasure and mastery while engaging in them, exploring alternative behaviors to reach goals, and role-playing to address specific deficits. Traditional cognitive behavior therapy also addresses the behavioral activation issues, but to a lesser extent. Interpersonal, family, and marriage therapy focus on improving the interpersonal relationship of the patients so as to prevent relapse. Educating people about their illness is a common component of treating many disorders, including bipolar disorder and schizophrenia. Psychoeducational approaches are commonly used in individual and interpersonal therapy. Typically, mental health professional helps patient and the family learn about the symptoms of the disorder, the expected time course of symptoms, the biological and psychological triggers for symptoms, and treatment strategies. Overall, combining psychotherapy and biological treatments in mood disorders is considered to be more effective in cases of moderate to severe depression. 2.9 Suicide. Suicide is one of the most tragic and serious aspects of mood disorders. At least 90% of the people who commit suicide have a psychiatric disorder at the time. Suicide attempts were earlier common between 25 to 44 years of age, but in the past few years risk for suicide has increased for all age groups. For instance, there has been a dramatic increase in recent years in suicide in adolescents. It is the third leading cause of death in teenagers after accidents and homicides. Children who have lost a parent or have been abused are at an increased risk. There is dramatic increase in suicide among elderly. Elderly suffering from chronic physical illness, widowed, divorced are more vulnerable. There is a high risk of suicide in all depressive states. According to WHO, one person dies by suicide every 40 seconds. India has the sixth highest rate of suicide in the world. Suicide is said to cause more death per year than homicide or war. People with depression are 20 times more likely to die by suicide than non-depressed people. The dual tragedy of suicide is that an individual who dies by suicide is experiencing severe psychological distress, and often the family who loses someone close because of suicide becomes vulnerable to psychological distress and illness. Suicidal ideation includes morbid thoughts related to one's death, killing oneself, funerals, etc. Suicidal ideation does not mean one will commit suicide, but such thoughts can be a risk factor. Suicidal behavior / deliberate self-harm may or may not indicate a wish to die. Some individuals indulge in cutting, burning self, and / or hurting themselves by other means. Suicidal attempt is a self-destructive behavior in which the person is trying to kill self, and finally suicide completion is a suicidal attempt that leads to death of an individual. Some of the commonly used methods include hanging, firearms, drug / alcohol / medication overdose, carbon monoxide poisoning, jumping from high place, and deliberate accidents to save family from the grief. For someone with depression, the lifetime risk of committing suicide is about 15%. Men commit suicide 4 times more than the rate of women. This is because men choose more violent / lethal methods of suicide such as firearms and hanging, whereas women try to use methods in ways that take longer and have higher chance of rescue, such as through drug overdose, poisoning, etc. A small minority is intent on dying. They give little or no warning, and generally rely on more violent and certain means of suicide such as shooting or jumping from a high place. About 80% of those hospitalized denied suicidal ideation the last time they spoke with a clinician before actually committing suicide. For many people, suicidal thoughts are often ambivalent. These individuals are not intent on dying but want to communicate dramatic gestures of distress to others. They may attempt methods with minor risks, like minimal drug ingestion. It is important for clinicians to focus on suicidal ideations of the patient as part of the treatment program for mood disorders. Suicidal prevention programs consist of suicide intervention by providing suicide hotline. 2.10 Let us sum up. Now that we have come to the end of this unit, let us list all the major points that we have already learned. Mood disorders are extreme variations in mood, either high or low, that cause significant distress and lead to significant dysfunction in everyday life. They are classified as unipolar and bipolar mood disorders. Presence of mania in bipolar mood disorder distinguishes unipolar from bipolar disorder. People with unipolar mood disorder experience some form of depression, major depression or dysthymia. Such individuals experience a range of cognitive, somatic, and affective symptoms including depressed mood, inability to experience pleasure, hopelessness, helplessness, lack of motivation, sleep and eating difficulties, suicidal ideations, and physical aches and pains. There is evidence of moderate genetic contribution for unipolar mood disorders. Genetic factors interact with a number of interacting disturbances including neurochemical, neurophysiological, and neuroendocrine. The most prominent theories of depression are Beck's cognitive theory, Seligman's helplessness theory and hopelessness theory. According to the cognitive model, individuals with depression have a cognitive diathesis, for example, depressogenic beliefs and pessimistic attributional style, that lies dormant for many years. Stressful events are important in precipitating an episode of depression. In the bipolar disorders, cyclothymia and bipolar I and II disorders, the person experiences episodes of both depression and hypomania or mania. During manic or hypomanic episodes, the symptoms are essentially the opposite of those experienced during a depressive episode. Biological causal factors play a more prominent role for bipolar disorder than for unipolar disorders. The genetic contributions for bipolar disorder are strongest amongst all adult psychiatric disorders. Biological-based therapies like medications or electroconvulsive therapy are often used in the treatment of the more severe major disorders. Biological therapies in combination with psychotherapy, cognitive therapy, behavioral activation treatment, and interpersonal therapy, are often advisable for more severe as well as milder forms of mood disorders.